Second basic protocol is a protocol based on GnRH antagonists, and there are 2 antagonists available in the United States. There are some advantages and disadvantages to antagonist management, but we can all agree that compared to luteal down reg, these are shorter protocols. These protocols usually begin with the patient's period and start, unlike a luteal down reg, which begins 10 days to 2 weeks before the period. And so the luteal down reg is a very long protocol, while a GnRH or cetrotide-based protocol is reasonably short. In the antagonist protocols, the patient will begin taking the FSH-containing compound on the first or second day of her period, and she'll take that drug probably 10 to 12 days. Usually on the 5th, 6th, or sometimes the 7th day of stimulation, but not after that, the GnRH antagonist will be started. And so the patient will be on only a combination of drugs for only a few days. The advantage to antagonist protocols relative to luteal phase downregulation is that they're shorter. There's no difference in pregnancy rates if you look at well-controlled data, no difference at all. But the antagonist protocols are shorter, so fewer shots. The intensity of the ovarian stimulations vary a little bit more with luteal phase downregulation, but for people who are trying to get really high responses, the luteal downreg is associated with higher response typically than an antagonist-based protocol. For people who are looking for a possible added measure of safety to avoid ovarian hyperstimulation syndrome, actually the antagonist protocols would be a better choice. So if you know you're a very high ovarian responder or you have PCO, an antagonist protocol is probably going to be a little bit safer for a number of reasons. One, because the stimulations tend to be less intense to begin with, but also because you can actually use a GnRH agonist to cause ovulation to occur. Now, there's some controversy about how effective that is in initiating pregnancy, but there's a lot of data now that says that that approach is perfectly fine in terms of egg number and quality, and there's virtually no risk of hyperstimulation when you do that. Now, the pregnancy rates might be lower, and that's one of the knocks on what's called agonist trigger. And there may be a way to work that out in terms of hormone supplementation after the agonist trigger to protect the pregnancy rate. But for right now, the jury's still out on whether it's as effective as the standard protocols.